I'm YuRi, I'm an AMU F2 at the moment, and I'll be presenting a case about when the hemoglobin drops. We will cover how to approach anemia, and I will go quite back to the basics that I learned at medical school for that. And then we'll try and apply the principles to a case that we saw in AMU last week. Then we'll talk a bit more about the diagnosis, which I will obviously not reveal right now, and especially focus on the diagnostic challenges of this diagnosis, including atypical presentations. And then we'll kind of wrap up to consolidate the learning lessons from this case of anemia. And we'll also touch on considerations when caring for patients who are Jehovah's Witnesses, and that will just be one slide. So this is the history of the case. She's a 60-year-old female. She came in with a 3-week history of diarrhea and vomiting. On further questioning, she also tells us about some shortness of breath on exertion and fevers. Her past medical history includes hypertension, proteinuria that was, we don't know the outcome of the investigations, calculus biliary tract, fibroids, and lumbar disc degeneration that causes her some pain in the back. Her drug history includes amlodipine, citalopram, lisinopril, omeprazole, and the occasional Zopiclone to help her sleep. She's got no non-drug allergies. She lives alone. She has a cleaner every Tuesday. She does mobilize with a stick due to the back pain, given the lumbar disc degeneration. She has about 15 pack years, but she stopped smoking a long time ago, and she does not drink alcohol or do any recreational drugs. She also mentions she's a Jehovah's Witness, so she will not accept blood transfusions if she needs that. Just to give you a bit more about the history of presenting complaint, if I remember correctly, she said there's no blood in the stool. She passes about 4 or 5 times a day. It's quite soft and watery at times. She has been vomiting 2 or 3 times a day. There's again no blood in there. On examination, she's alert and orientated. She's apyrexial. Her chest is clear. There's good air entry bilaterally with a normal respiratory rate and normal saturations of room air. She's heart rate's 80, her blood pressure is 103/64. This might be on the low side for her, given that she has hypertension. Her capillary refill is normal, the JVP is not raised. Line standing blood pressure reveals a borderline drop. The abdomen is soft, there's no organomegaly, and the bowel sounds are present. ED also did a PR. There was no bloods, melena, or masses, and the soft brown stool on the glove. The calves were fine, there's no peripheral edema, and a gross neurological exam did not reveal any focal deficits either. So A&E obviously did some bloods before they referred to medical team. So the ECG showed sinus rhythm, about 90 to 95 beats per minute. Her urine was negative for ketones, nitrites, blood cells, protein. And the VBG showed a mild alkalosis, but most parameters were in range of note. Hemoglobin is 70, so on the low side. The lactate was normal and the glucose as well. And the bloods done in ED again showed a low hemoglobin of 71, white cells of 4.5, and a low platelet count of 79. There was a very, very mild raise in ALT and a mild raise in bilirubin as well. And the amylase is normal, and so are her electrolytes. The chest
Sorry, YuRi,
yeah?
Modax asked a post-COVID world question.
Oh, sorry, I didn't see that.
Has there been any foreign travel recently?
Thanks for asking. No, very good question. She hadn't traveled anywhere recently. Thanks. Thank you. Just interrupt me with the questions if I don't see them. The chest, and I will have my questions as well. Chest X-ray is clear. So she's just been referred to medics asking, is this maybe a GI bleed? Could you help us, please? So I don't know if anyone can just put in the chat or unmute themselves. What are your thoughts so far in terms of differential diagnosis? I'll just wait for maybe 1 or 2 inputs and then move on. And what would you do for the patient?
Right, come on, everybody. Someone needs to say something on the chat or.
I pick on people. Modak, you're here. Hi, you're my colleague. What would you do in this case? You can put it on the chat if you'd like. And see if I recognize anyone else. Probably not. Yeah, there's something in the chat. Aplastic crisis. So we're thinking something about bone marrow, right? Because there's a bicytopenia. Anything else at all?
And just to recap, there was no blood in the stool and all those things you did. You did the PR, brown, soft stool, you said, yeah. So still no loss of blood as far as you can tell. Is that correct?
Yeah, that's correct. Based on the history and the PR. exactly.
Although your last slide did mention GI bleed, but there's no evidence of that, correct?
Yeah. So I think that was the ED referral. They were querying that given the low HB.
Okay, somebody wants a blood film.
Yeah, that's a good point. So we'll probably get that.
Mhm.
I'll move on. So I think we reclocked a patient and then talked to gastroenterology given the low HB. The initial advice, and I think this telephone referral was done without sort of exchanging the Cerner number, just saying low HB, could this be a GI bleed or a malignancy causing this? And the verbal advice on the phone was, well, we could do a colonoscopy. It was the evening, so they said probably during the week or in hours. We could, if she refuses blood transfusion and the hemoglobin drops further, we could give an iron transfusion, and you should set the hematinics. So we did that. And I think I'm also going to show you the bloods from the next morning. So the evening of the day of admission, these are the bloods you just saw. The B12 came back very low, at less than 148, roughly 200 to 800 is a normal range. I haven't put the units here just to keep it simple, and the folate was in normal range on the low side. The next morning, because we had the bloods before we basically evaluated the patient again, the white cells had dropped to 3.2, the hemoglobin was 55, the platelets 66, and the ferritin came back as well as part of the hematinic screen and the whole iron status, but ferritin is, I think, very much telling us this patient is not iron deficient. It was in the normal range at this point.
And you hadn't given iron?
Not yet, no. So on that first day in the evening, she was prescribed hydroxycobalamin, so vitamin B12 in IM injection. And then the next day, as we know, we need to do that as a next step after B12 replenishment because of the risk of subacute degeneration of the cords. We give folic acid from day 1 onwards. Okay, so I think as we do on the ward round, we then wanted to chase the specialist opinion afterwards. So we discussed with gastroenterology given the hematinics results. And then the registrar had a look with the referring junior, and they said, hold on, look, the MCV is 115. This is a macrocytic anemia. I don't think this is a GI bleed, even if there is a significant hemoglobin drop. It could be masked, obviously, but maybe send a TTG to look for celiac disease, which could be a gastrointestinal cause of malabsorption, but I'll get back to that. And then we could do a CT cap as a first step, and endoscopy maybe as a lower priority next week. And then they said you should discuss with hematology given the significant low hemoglobin. So we did talk to hematology, and this is when I met the patient, and I think we had the MCV of 115, I added up and reticulocyte count, which is normal. And we also had the next bloods back. So in my opinion, this kind of confirmed this wasn't a spurious result. The white cells, hemoglobin and platelets remained low. The B12 was replaced and the folate level had dropped. So I talked to hematology. Some of the thoughts we discussed were, could this be a lab or sample error? Could this be a blood repeatedly taken from a drip pump because she did have some fluids as she wasn't eating much? Could this be microangiopathic hemolytic anemia or bone marrow disorder, as Modak said? Could this be aplasia of the bone marrow malignancy? Could this be nutritional B12 and folate given the macrocytic anemia? So basically we said, first of all, we need to rule out the dilutional drop. So I'm going to take the bloods myself. We did that and we confirmed basically this was not a dilutional drop. And then as Modak suggested, we should do a blood film. So they will chase, they had already had a referral for the blood film, thyroid function and HIV serology, and we should replace the B12 and folate. And if both, they'll also consider replacing other nutritional vitamins. So just in case, I also prescribe some Pabrinex, which is cheap and very effective. So I'm going to soon get to the next question, but just I went back to the patient, asked a few more questions, and the patient had some drenching night sweats, which actually preceded these symptoms of the gastrointestinal symptoms. Subjectively, she said the diet could be better. She was not very specific. I think the clerking said that she was eating mainly porridge and water before admission because she wasn't tolerating much food and didn't have an appetite. She did have healthy snacks and fruit by the bedside, I noted, and she's not a vegetarian, if you wonder. Her MCV was, as I said, high. I checked the LDH and the retics as well, and the LDH was in the 3000s, so that's significantly high. And the retics were 22, which was confirmed on a repeat test. We were still waiting for the blood film in the afternoon of day 2, I think it was. Any other thoughts now, given these results? Autoimmune hemolytic anemia. Yeah, so we're thinking more hematological causes, like as the heme said, maybe a MAHA. Anything else that goes through your mind at all? Does anyone want to unmute themselves?
You'll put the numbers back. Just go back a slide with all the numbers on it.
Sure. Let me try.
There.
So I've noticed the retics are not reported as a percentage in our trust. Is that I thought that was the normal way of reporting it, but basically this isn't the normal range. I checked. I think 17 to 90 is the normal range.
So do you think normal is appropriate for an anemic patient?
It's probably not. Yeah, I think I would expect it to be high in this case, but I don't think the heme felt it was in the range also to warrant the thought of aplastic anemia at this point.
No, indeed. So it's not low. So if you've got aplasia, then you've got no retics. I've got some retics, but not enough.
Yeah. So the bone marrow is struggling potentially. Yeah. Okay, so we've had hemolytic anemia as an additional differential. I'm going to move on. So do
you not think hemolysis is a bit less likely because the retics are really high?
So I think the LDH probably pointed towards this. The retics are not high enough, and I think the bilirubin was normal at this point. I know there was 420 on admission, but basically it normalized the next day. So I think there wasn't much evidence, but obviously the blood film would be very telling if there was the case with significant cystocytes fragments.
Right.
So should we move? And she had no clinical signs of it either.
Sure.
Although the drop is quite significant, isn't it? So in terms of the blood film, let me just drag the chat to the side. How do I minimize this? Could anyone tell me what you see on the blood film? I have discussed the blood film with the heme as well, as I'll try and analyze it after someone has a go.
Come on, someone unmute and say what you can see.
Don't ask me and Prof. Moen to pick on anyone.
Okay, so Murdak's written the answer in the chat.
Thanks, Modak. Hypersegmented neutrophils, yes. So the definition of that is 6 or more segments of the neutrophils. So I can count at least 7 here. So that's definitely the case.
Was this from the patient?
Sorry?
Was this the actual patient's film?
So no, they had the heme thought it was in the lab, but we couldn't find it. So he sent me one that was basically the same.
Yeah, okay.
Right, so shall I analyze it a little bit?
Yes, please.
So this is a hypersegmented neutrophil, as Modak said. This is a very large blood cell, red blood cell. So this is a megakaryocyte. This is not a megaloblast, which would be mainly seen in the bone marrow. This is a little fragment. So this could be a type of cystocyte, but there's only one of them. This is a teardrop, and I think there's another one here. So those dacryocytes, so dacryos is tear in Greek, usually signify some extramedullary hematopoiesis. So might again mean that the bone marrow is struggling in a way. So we see macrocytic anemia, this was the report, anisocytosis, so I didn't mention that. So the red blood cells are of different sizes, dacryocytes, no target cells, which is very important. I'll tell you in a second why. There's very occasional fragments, but it's less than 5 per high power field, so not many. And macrocytes and hypersegmented neutrophils seen, as Modak said, and there's true thrombocytopenia, which we can't tell, I think, from this single small photo. This is something that I learned from the heme. So there are no target cells, which usually look like this. And this is quite significant because when we look at the differential of macrocytic anemia, there are lots of causes that cause membrane problems, such as phospholipid problems. And those would usually cause the membrane to be dysfunctional, quite large, and fold over the red blood cell. And then it would look like this, like a target. And the absence of target cells is significant because it decreases the likelihood of many other causes of macrocytic anemia. Why can't that report read as big red cells of different size? Well, this is how medicine is, and we like our jargon, don't we? And features consistent with megaloblastic anemia was the impression. And then they asked us, please to check, replace folate and B12. And if counts fail to recover after replacement, please do refer to hematology. Do we have any other questions at this point? I'm going to move on. So just a quick, yes?
What's actually in it? Is it vitamin B and C and What's actually, and it's all thiamine, and there's ascorbic acid, but has it got folate? I just don't know.
Ooh, that's a very good question. I have no idea, to be honest. Does anyone know? I'm going to have a quick Google now. Actually, contains B1, B2, B6, nicotinamide, vitamin C, and glucose.
So no folate.
No folate, no.
I think B9, I think, but okay.
So the interim summary before we go to anemia is she's a 60-year-old, diarrhea and vomiting for 3 weeks, fevers, night sweats, fatigue for a bit longer than that, anemia that seems to have involved the HB drop with a high MCV, bicytopenia, which seems to have evolved into a pancytopenia on the second day, but the white cells are recovering now, I think. And then B12 deficiency on admission, now replenished, but the bloods are showing a folate deficiency, and the blood film shows a megaloblastic anemia. The LDH is raised, the retics are normal, and the ferritin is normal. So, back to basics, how do we approach anemia? I think everyone knows, so I'm just going to skip this question. Microcytic, normocytic, and macrocytic, but this is quite key because I don't think we all looked at the MCV on admission. So if you look at the causes of each type of anemia, the way I remember, because I'm again studying for MRCP now, and this is how I did it in medical school, I remember the microcytic anemia as an iron-last, mnemonic, iron deficiency, lead poisoning, which is such a rare cause, but we all like to remember that, anemia of chronic disease, sideroblastic anemia, one of the causes, lead poisoning, and thalassemia, with a very, very disproportionately low MCV. ABCD is normocytic anemia. So again, chronic disease can cause this, which is malignancy and CKD, but the other causes are aplastic anemia. So one of the differentials that someone brought up, bleeding, especially chronic, can cause also normocytic anemia, bone marrow failure, hemolytic anemias typically cause normocytic anemia, and therefore also intrinsic RBC defects and endocrine causes and thyroid disease. And macrocytic anemias, this is my favorite mnemonic, is fat RBCIM for me. So pregnancy, alcohol, thyroid disease, significant reticulocytosis, which we do not see in our patients, would also cause a macrocytic anemia, B12 and folate deficiency, cirrhosis, antifolate and other cytotoxic drugs, and further bone marrow problems, myelodysplastic syndrome, and also multiple myeloma. So we're going to focus on the ones on the right. Let me just close the chat again. These are the simple things we can do in admission. Not expensive, very quick. Alcohol history, drug history, LFTs and TFTs. You can also screen for more sort of synthetic function bloods, obviously for the liver and AST level to look for alcohol excess. Reticulocytes can always add it onto bloods and hematinics as well. And then we can request a blood film if it's not already in progress. Then if we, so because the patient was B12 deficient, has megaloblastic anemia, I'm just going to hone down a little bit more on that. So I think the consensus is definitely present in animal protein. I haven't looked in too much depth, but I think some people also say is found in some nuts and fermented beans. But I think the main source really is animal protein, and therefore vegans and vegetarians can be at risk of vitamin B12 deficiency. However, stores last for a very long time, for years. So it doesn't occur until like a very long time of deficiency. To look at the pathophysiology, I don't want to bore you, but I think this is quite important for our case. And when you take in animal protein diet, the vitamin B12 or cobalamin is complex to it. And then partially the amylase in the salivary fluid, but especially the hydrochloric acid in the stomach will dissociate the cobalamin from the animal protein, and it will be complexed with haptocorin, or also called R protein, which is released from the salivary gland and meets the cobalamin in the stomach. This transports the cobalamin without it being digested or get lost in the stomach through the intestine, and in the pancreas then adds the amylase to split the cobalamin off the transport protein. And then this is where it means the intrinsic factor, which is produced by the stomach and is, I think, classically the only essential function of a stomach, and transports this to the terminal ileum where it's absorbed through the brush border. So diseases or problems that affect any part of this whole process of B12 absorption can cause B12 deficiency. Okay, so What are the causes of cobalamin deficiency? I'd like a little bit of participation on that one, if possible, please. If anyone can unmute or write on the chat. I've lost the chat. The chat's here. Is there anyone who vegetarian diet? Yeah, vegan diet especially. So veggie diet probably is still sufficient. Anything else at all? So that's the first step, isn't it? So the intake of food. Anything else along the absorption of vitamin B12? Celiac disease, yes, exactly. So that would affect particularly the small intestine. So that can cause B12 and often folate and iron. You see, yeah, hookworm infection. Yeah, I have one of those in the next slides. Great. Anything else at all? Okay, so I'm going to.
Wait, here we go. There's a
Oh,
couple.
we got loads of them. Okay.
Terminal
Ileum resection. Yes, yes. So resection, short bowel, removal of the ileum, removal of the stomach, all of that. Pernicious anemia, yes. And autoimmune, I think you might refer to the same thing as Hina. So pernicious anemia, yes.
And then there's Crohn's, which affects the terminal ileum.
Yes. Okay, I think we've got most of them. Should we look at the list? So I've made it alongside the diagram again to show you. So decreased oral intake. I should put vegan diet, sorry, vegetarian diet is probably not quite adequate, but vegan diet and malnutrition. Then malabsorption, gastric causes. So obviously gastrectomy, as one of you said. Severe H. pylori gastritis can also cause it. Pernicious anemia, as you said, and because the stomach produces the intrinsic factor, specifically the parietal cells. Long-term PPI therapy. So the patient is on PPIs, I just noticed, but that can also cause it because it will inhibit the hydrochloric acid production, I think. So that might be the cause. Malabsorption, intestinal causes. So you've already mentioned Crohn's, celiac, ileal resection, surgeries that can cause blind loop syndrome and small bacterial overgrowth can also cause malabsorption. This is a fancy tapeworm. I think, fun fact, it's the largest parasite that can infect humans. I might be wrong, but that's I've been told. And it can be up to 9 meters long. Not really found much in Europe, and this patient didn't have a travel history, as Modak clarified earlier. So this can cause intestinal malabsorption of B12 and B12 anemia, and severe pancreatic insufficiency can also cause it because you will lack this, sorry, I didn't do my animations, this step at the intestinal levels. So again, some simple things you can do in ED and AMU are things like you can look at the diet, ask the patient what do they eat at the moment, are they struggling to eat, hematinics, TTG, CRP and ESR to look at these intestinal causes. Intrinsic factor and parietal cell antibodies can be sent off and they take about a week. And fecal calprotectin and elastase, these are some tests as well you can send off, take a little while. And then OGD and H. pylori testing could be also an option to look at in the first few days. Any questions? Should we move on? So we had a few further bloods. On the third day, her count seemed stable and the white cells recovered a little bit, still leaving that bicytopenia. Definitely not taken from a drip arm. And ferritin is maybe dropping a little bit, but still in the normal range. And the reticulocytes were actually stable on day 1, 2, and 3. So we did those further investigations, and the thyroid function showed a slightly low TSH. I think Prof. Mirren or Dr. Akram were my consultant that day, they were like, this is sick, your thyroid. It was added on from the first day bloods. HIV serology was negative, TTG was negative, and then a week later we had some more results. This was on the gastro ward where the patient was eventually intrinsic factor positive, gastric parietal cell antibody weekly positive. They did an autoimmune hepatitis screen, which is negative, and the stool cultures were negative. So what is the diagnosis?
See, this is where you want A, B, C, D, and E, and then people can choose.
Sorry?
Yeah, it's on the screen. It's on the chat rather. Pernicious
Oh,
anemia.
it's in the chat. Okay, perfect. Pernicious anemia. So I keep moving the chat because otherwise I can't see my own slides. So I'll give you a little bit of history bites and a little bit of pathophysiology just because it sticks better if we do it that way. Very interesting. It was first described by a surgeon in Britain in the mid 1800s, James Combe. I think he looked at a few cases of atrophic gastritis associated with anemia and described them. But I think the people who really characterized the symptomatology were Thomas Addison in the UK. We know that he's discovered Addison's disease, but actually the second disease he discovered and described was Addison's anemia, which is pernicious anemia. And then also independently a German guy, Michael Birmer, or Michael Birmer, I guess, described the disease as well. And he's the one who coined the term pernicious anemia or pernicious anemia, which I don't need to translate because it means an insidious onset, very slow, very insidious and subtle onset of anemia with neurological symptoms typically. Another fun fact, the first Nobel Prize in Physiology of Medicine that went to America was actually for this disease. And one of the recipients is Whipple. We know him because he's got Whipple's disease. And they discovered that liver therapy, eating raw liver, can cure some cases of anemia. So that's a bit unusual, but and then the Cobalamin was identified as culprit substance a few years after the Nobel Prize, meaning many years after the discovery. And that makes sense because I said earlier, B12 is stored in the liver for years. So looking at this diagram again, as we've seen, B12 needs intrinsic factor for the absorption. And the pathophysiology, I don't think it is very much well known, and there are not many recent papers on this, but it usually involves either or both anti-gastric parietal cell antibodies, anti-intrinsic factor antibodies, and then you get malabsorption of B12, which then causes reduced red blood cell production, as well as reduced myelination. And these classically causes Megaloblastic Anemia neurological features. And I'll show you a little list of features, which I have from the website of the Pernicious Anemia Society. So obviously you get anemia, especially if you're anemic, pallor, fatigues, shortness of breath and exertion, and postural hypertension. So I've highlighted in light red all the ones that a patient did have. Constitutional, so you can get fever, night sweats, sleep disturbances, hair and nail problems. Neurological problems, paresthesia, numbness, and limitus. And I think this is how we usually learn about it in medical school. You get peripheral neuropathy symptoms, ataxia, areflexia, aphasia, and other sensory disturbances such as vision, hearing, taste, and smell disturbances. And then you can also get neuropsychiatric features. And this is, I think, part of the reason we screen as part of the confusion screen, B12 and folate. So it's called megaloblastic madness in the past. And there's lots of case reports actually on TTP-like presentations, which then turned out to be pernicious anemia because you would get neuropsychiatric symptoms as well as an anemia and some thrombocytopenia, and sometimes even hemolysis actually. Delirium, memory problems, personality changes, so non-specific. And you can get gastrointestinal problems. So our patient actually had diarrhea, nausea, vomiting, anorexia, so a more gastrointestinal predominant picture. And you can get genitourinary problems, such as infertility, incontinence, recurrent UTIs, and loss of libido. If I checked on recommendation by the hematological registrar, the guidelines by the British Journal of Hematology regarding the diagnosis. So this might be quite useful for you guys. So full blood count and blood film, of course, as you suggested, hematinics, which we just request, but they come usually with the Cobalamin assay and the folate level. And separately, we usually request an iron level, iron status. Of interest, the serum cobalamin levels can be affected by folate deficiency pregnancy, the oral contraceptive, metformin, HIV infection. So all of these usually drive it down, and it can be a false positive basically by being quite low. So that's something to bear in mind, but there are other tests that can be done. Intrinsic factor antibodies have a sensitivity of 40 to 60%, but a specificity of near 100% and a positive predictive value of 95. This means if someone has intrinsic factor antibody, they very, very probably definitively have in pernicious anemia, whereas parietal cell antibodies, even though pathophysiologically would make very much sense as well, actually less specific, and they are found in 10% of the general population. These are the guidelines by the BJH. All patients with anemia, glossitis, neuropathy should have intrinsic factor antibody tested, regardless of the cobalamin level, which can be normal. If you have a normal cobalamin level, and I think that happens in 1/3 to 1/4 of 1/4 of people. You can look at further tests such as holotranscobalamin, methylmalonic acid, and homocysteine. Does anyone know which direction they would go if the person has pernicious anemia? Don't know if you want to have a guess, just so it sticks a bit better rather than me just telling which direction it would go. Oh, I had a few questions. I'll answer. Yeah, increased. Okay, all of them. So I think holotranscobalamin, if I'm right, would be decreased, but the other two would be increased. Oh, is it? Yeah, exactly. So because cobalamin is needed as a cofactor for the enzymes that convert methylmalonyl-CoA to succinyl-CoA in the Krebs cycle, I think. And therefore you will get accumulation of MMA, which would be high. And similarly, homocysteine is converted by MMA to methionine. And you need both cobalamin and folate for this. Therefore, MMA is actually less specific and it can be raised in folate deficiency, which might not be very helpful if you're looking at megaloblastic anemia with a normal B12 level. That's something to bear in mind. But homocysteine is actually very, MMAs, yeah, so but they can be requested as part of the workup. Is it an assay problem results in cobalamin being normal? I think, I looked it up. I don't think it is for the ones I looked up, maybe folate deficiency, but not for metformin and pregnancy. Pregnancy is thought to lower the levels physiologically in the first trimester up to 30%, or I think up to third trimester. Is that right?
What's the assay problem? Was the cobalamin not low though? I thought it was low.
Yeah, so it goes lower.
It was in your patient, wasn't it?
It was low, yeah, it was low. It was normal, yeah. So as in expected for pernicious anemia, but it can be falsely low in, or like it would be low and expected low in pregnancy, folate deficiency, and metformin sometimes. And metformin, I think it's due to sort of subclinical gastric side effects. Can be normal in patients with functional B12 deficiency. That's really interesting. Nitrous oxide use, yeah. So there's lots of caveats, and I think that's why you can do the extra tests. And then you should also do an OGG gastroreferral because of the causes and consequences and maybe concurrent diseases of gastric atrophy. And there is a risk of gastric cancer and carcinoids in pernicious anemia. It's based on small observational studies, but it does exist. So therefore, and also you would consider the workup differential and concurrent diagnosis, which we've kind of covered on the way, at least superficially. Is that okay? Should I move on? So the diagnostic, so a classical megaloblastic anemia patients would have a low serum cobalamin level, anemia with high MCV, and a rise in HB following treatment. And this was actually present in our case. There are other diagnostic challenges, those are obviously atypical presentations. You could get neurological features only. You could get GI features only, like in our case. You might get normal level serum cobalamin. You could get no anemia, and again, that's the case I think for a quarter of cases. You could not get macrocytes, and I think that especially happens with concurrent causes for microcytosis, which then causes a normocytic anemia if it's present at all. You could get no autoantibodies. So again, I think because the sensitivity of these antibodies is quite low. And you might not see a clear improvement because some features might be irreversible, especially advanced neuropsychiatric features. And I think we always do B12 screen as part of a confusion screen, but I think the Cochrane evidence for actually reversing dementia and cognitive impairments very, very low by just supplementing B12. Not saying that we shouldn't do it, we should probably do it anyway, but that's the thing. And then just another curious point on LDH, because I think Prof. Miran and I were looking this up after our patient had very high LDH. Actually, this very old papers in the 60s, not just this one, several of them showed that I think the LDH is high in these patients. Quite interesting. This is iron deficiency anemia, megaloblastic anemia, and hemolytic anemia. So it's not necessarily specific to pernicious anemia in this sense, but our patient would be here in the 3000s. And both enzymes, LDH, I think was part of converting pyruvate kinase, and followed LDH. But anyway, and then the other enzyme in the same metabolic pathway, they are very much raised in megaloblastic anemia. So this is not atypical, it's my main message here. In terms of management, so what is the management of B12 deficiency in pernicious anemia? Does anyone want to tell me how we replenish the B12? Ion injections, yes. Can we give it orally? Yeah, so Modac says we can follow it with oral. So this is what I've got, and you can add if you know more about it than me. So yeah, you do start with intramuscular. Usually it depends on the presence and absence of neurological symptoms. So if you do not have neurological symptoms, it's 1 milligram thrice a week for 2 weeks, and then the maintenance dose where you have an injection every 3 months. With neurological symptoms, you can get a higher sort of dosing regime where you give alternate day IM injection. And this is actually what we did with a patient, even though she didn't have neurological symptoms, given the severity of the anemia and the fact that in her case, she wasn't going to have transfusions. And then you give a maintenance dose every 2 months. Oral, I looked this up briefly. I think you can give oral, but usually you prefer IM first just to correct it more quickly.
So
And
if they've got no intrinsic factor,
yeah,
absorb the oral.
that's a good point. I actually didn't look that up specifically. Probably not, you're right.
I mean, I know they give IM for life. We've got patients who've got patient anemia. They have it, they're entitled to it. They have every 3 months to go to the GP and get an injection.
Probably not without intrinsic factor. Because it's a lifelong condition, really, they need supplementation all their life. I think it was more of a topic during COVID as well, because patients couldn't come in with, I have to have IM injections very frequently, but I think you're right, this probably just applies to every other cause of B12 deficiency apart from pernicious anemia then. So yes, they will have to have IM. And why is it so important to treat? I think some of the complications, subacute degeneration of the cord is classically precipitated if you supplement the folate, but do not give the B12 first, and the bone marrow then consumes and goes into very severe B12 deficiency. But it can occur also just as a sequela itself. And cognitive impairment, heart failure due to anemia, gastric cancer, as I mentioned, these are all other complications that should be prevented by treating this condition. These are our patient's bloods. So we gave her hydroxycobalamin. We gave her folic acid, given that it dropped as well. And I think we discussed this and we thought it was because the bone marrow is consuming and working hard, and therefore the hematinics will actually need constant checking and replacing. The symptoms improved pretty much. This is quite impressive. I'm not sure if it was coincidence or actually because of the treatment, but her night sweats, diarrhea, and vomiting actually all settled a couple of days into admission. And I confirmed this with her on discharge. And she said, yeah, it was while I was in AMU, they all stopped.
Have you got the retic counts? Did the retic counts shoot up after the IM B12?
No, they didn't check them on 7.
Oh, shame. Okay.
Yeah. When I checked them, it was like 22, 16, and 21. So there was no trend in the first 3 days. And they usually fast are changing, don't they? So, yeah. So I followed her up remotely, and then I had a chat with her before she was discharged. So she had vitamin B12 and folate replaced. As I said, her symptoms settled. She moved to 7 West, the gastro ward. They did a CT, which showed some stones in the gallbladder. I think this is known given that she had unclarking calculus biliary tract. There was no malignancy as far as the study could see. There was increased density of the marrow in the proximal femora, which I think this could imply some extramedullary hematopoiesis. I don't know if I'm right here, I'm just speculating. So I think this is also with that karyocyte. I thought maybe she already started compensating for this anemia. And then sustained clinical and biochemical improvement, as you saw on the graph. And then once the hemoglobin was 70 without transfusions, as per patient's wishes, she was discharged with IM B12 injections in the community. She was still feeling weak, but all her other symptoms basically had settled, and she has an OGD and gastro follow-up, because that's indicated, as I said earlier, given the atrophic gastritis and the risk of malignancy. Just a very quick word, because
just before you do this, if she was not a Jehovah's Witness, would you give her any blood?
I think in practice we might have, because she ended up staying for almost 2 weeks, didn't she?
But we should we? We should.
Yeah. So the hematologist said they should recover. So if the patient doesn't want to, we as in her case, she will just recover. But I suspect maybe we would have hurried into transfusing her. I don't know if that's
Yeah,
right.
we shouldn't though. We shouldn't, because if you've got a cause like this that is definitely reversible, why give them blood and give them all the antibody problems of the future when they'll make the ticks very quickly? Because she's responded quite quickly.
Yeah, it was quite a good, I think, sustained improvement. It went over 70 maybe a week later.
Yeah.
Right? Also,
Yeah, so we should not give blood if we can avoid it.
Yeah, and I think that's a good learning point as well, because I think maybe with the hemoglobin of 50, many people would have been tempted. At least for me as a junior, I would have thought we should give blood.
Yeah, but you need to give volume as well if you do that. And so in someone who's, because she's not dry.
She maybe was a bit dry in admission, but I think she wasn't eating much.
I mean, I think blood is very useful if you're bleeding, then you absolutely must give blood very quickly if you've got vomiting blood, but this patient clearly isn't doing that. So hey, that's good, thank you.
And then just a quick slide.
We can do a poll. Okay. Let's do a poll now. I feel like I want to use a poll. Okay?
You want to use a poll? Okay, you did a poll.
Can I do that? So I'll just set the poll. Relaunch. Okay, so your options are A, give blood. Okay, A, give blood, and B, don't give blood. So I want you to all vote and see. A, give blood, and B, don't give blood.
Maybe go with what you would have done without our conversation.
Of 50, was it 50?
Yeah, 51 was the worst.
Okay.
He's symptomatic, anemic, 51. We're waiting for this.
And we know the patient's got pernicious anemia because we saw the film, yeah? Right, everyone, you need to vote. Now I've got 25 people on this call, and I want you to all just click A.
To be honest,
blood,
I would have given
A, give blood, or B, don't give blood.
Rest of the diagnosis, and then basically, if you look after a patient, there's a 24/7 line that you can call in emergencies at all, because and as a rule of thumb, they will refuse transfusion with whole blood and cells derived from whole bloods, but not further derivatives. This in the guidelines or in the consensus is basically you make your own informed decision for the individual who is a Jehovah's Witness. So I think don't make an assumption, but obviously check capacity. And then there's always a helpline in emergency situations that you can call even overnight. Learning points. So when the hemoglobin drops, never forget the basics. Go back and also check whether it's micronormal or macrocytic. In terms of pernicious anemia, I shared some history bites and some fun facts. We went through the pathophysiology, which was relevant to looking at the causes. Features-wise, be aware it might present just purely neurological, purely GI, or just even without anemia. Investigations, we looked at the diagnostic approach of both macrocytic anemia and specifically pernicious anemia. Bear in mind the LDH might be very high, so this is not a distractor. And then treatment considerations. So you should monitor and feed the hungry bone marrow. And you do actually end up referring to gastro for an OGD. This is a learning point for myself as well, to look at causes, complications. And Jehovah's Witnesses, there's a 24-hour line that you can seek help from if needed. Just wanted to thank Dr. Tark and Professor Miran for this opportunity, and the HemReg, Dr. Adams, who exchanged a few emails with me for this, and the patient herself, who put me in touch with her liaison committee. And yeah, thanks.